Today I want to talk about the dreaded disc herniation or low back pain that seems to be radiating. Hey, I'm Dr. Gouveia and I want to dispel some myths, provide some true facts about what a true disc herniation is and how we can treat it. Everybody's got a story about a pinched nerve in their low back or they know somebody who has one. Well, today we're going to show you what an evaluation of that disc herniation actually looks like. You know, whether we feel we need to send you out for imaging, do you need an orthopedic consult? We're going to answer all those questions in the following video. I also want to touch on some of the treatment things that we do here in the office, some exercise treatments, some of the tools we have like a traction table. They're going to show you that a lot of these cases, if not the majority of these cases, can actually be treated conservatively and that you do have options if you're dealing with that low back pain that's central in the low back, traveling down the leg, worse with sitting, gets a little bit better with walking. So stay tuned for the video. As we go through it, please prepare any questions. You can ask them in the comments. We'd be happy to answer them for you. Okay, so I want to dispel some myths right off the start. Every single case of disc herniations do not need an MRI, and every single case of disc herniation does not need surgery. Doesn't mean that those are not useful tools, or it doesn't mean that they're not something that occurs, but we can treat disc herniations very well with conservative management, with education, with different lifestyle changes, and we only send for an MRI if we feel it's absolutely necessary. When does an MRI become necessary? Well, when a disc herniation actually impinges on the nerve and you start to have motor weakness, so your legs or whatever it might be is not as strong, or you start to have change in reflexes. We're going to test that here in the office. Those types of progressive, more advanced cases of disc herniations may require an MRI to rule out more serious impingement on the nerve. Well, I'm talking about all this impingement on the nerve. I actually want to use a model to show you exactly what's happening so we can get a clearer picture. If we look here, this is a model of your lumbar spine or your disc, your vertebrae. So you have the bone here. This is the disc itself. It's got a strong outer rim, and then inside of it is actually like a jelly donut. This is the back side of your spine here. These are the bumps you feel on the back of your spine. If you look here, there's a little red mark. That red mark shows inflammation or an injury to the disc itself. When we have that, so if we forward flex, so if you picture bending forward like this, you actually move forward. The actual vertebrae move forward. When that happens, we predispose to the disc herniation. So look at that red mark there. We're forward with pressure, and all of a sudden you have this like jelly donut-like substance that can impinge on the nerve. Right here's your nerve. And if you can imagine that gets big enough to push on the nerve, it will cause pain traveling down to the leg where the nerve actually supplies, or it can cause inflammation. It can cause all kinds of different issues. So depending on how big that bulge is, also can indicate, in some cases, how severe your condition might be. So I think that's a really important visual because a lot of our treatment, if we think about this, is actually putting the body into extension. So if forward flexion, again, let me just kind of demonstrate, being forward like this actually pushes down and opens it up, causing that herniation to get worse. A lot of times we're gonna use extension, so going backwards like this as the treatment, because you can imagine if we actually push backwards on the spine like this disc herniation, it doesn't come out. You can see it stays there until we go forward and then it goes backward, goes out on the nerve like that. That's really important. One of the other things I talk about in terms of our treatment is lifestyle modifications and how to avoid actual aggravation when you have a disc herniation. We go over it in depth with our patients, but one of the most important tools that we can use is a lumbar roll. You can actually supplement it with a rolled up towel. It works really well. These are cheap. You can get them on Amazon for about 20 bucks. But what they do is, we talked about extension, they keep your spine into an extended position when we're sitting, whether it's in the car, whether it's when we're at work. And so what that does is it avoids actually increasing that opening of the vertebrae so the disc squeezes out more. So it keeps us in a position that avoids the increasing inflammation, increasing irritation. When we're in an acute case of a disc herniation, it just started, it's really intense, our main goal is modify our life so we don't keep irritating it. So spending more time in extension instead of flexion. This lumbar roll put at the base of a chair in your car, it accomplishes that. So it's a really, really important tool that we recommend to our patients when they're in that initial really flared up stage. We're going to talk about some of the exams that we're going to go through now that you understand a little bit more about what's going on and some of the things that you can do at home to help mitigate and eliminate some of your aggravating factors. As with everything we do at HealthFit, it doesn't matter what you present with, the examination is arguably the most important thing that we actually perform when you get to the office. So I want to actually take you through what that neurovascular exam looks like, which is the first step, trying to determine, okay, how bad is this potential disc herniation? We've already heard the history from the patient. It's pretty clear that the pain's driven from the back. Well, let's take you through what that exam would look like. The first thing is we have this really scary looking tool, but what this actually does is it's a pinprick test, and it's used to determine sensation, so true sensory deficit. When someone says, okay, I have numbness. Well, do you truly have numbness? I'd have the patient close their eyes, and we would go through on both sides, asking them if they feel the same or if they feel different. We go through all what we call our dermatomes. They're basically what nerve root might be affected in the low back. This is to really get a true sense of, is there sensory loss? The next thing that we're going to do on all of our patients is we're actually going to do a reflex test. So you've seen it in the doctor's office. We'll test, okay, do they have good reflex? He's got a brisk reflex right there, but it's even on both sides. We're going to do that for both the Achilles reflexes as well. These can be affected by disc herniations. They're really, really important that we're checking them. The final part of our neuro exam here is actually going to be a strength test. We're going to go through a bunch of different muscles, but I'll have him try and lift his thigh up to the ceiling against my resistance. Same thing here, kicking his shin into me, kicking his shin into me. And we'll go through all the different levels. Each muscle refers to a different section of the low back, and so it can help guide us. These three tests are really important. Remember that comment I made about, do we need an MRI? These may drive our decision making in that regard. If these are really, if there's big deficit or they're struggling with some of these tests, well, then we might get imaging. If it's normal, which it is in most disc herniation cases that aren't progressed, well, then we can move on with conservative care. The next test that I like to see is called a slumps test. The way that we do this, we're actually going to traction the nerve, is going to straighten this leg out, going to point the toe up. I'm going to have the patient tuck their chin down in their chest and ask them if they feel any symptoms. This leg should be straight. He's got a little bit of tension in that hamstring. But what we're looking to see is, does that reproduce the symptoms? Does it shoot it down the leg? If it does, that's positive for potentially nerve involvement. We'll confirm that test with a couple others that we'll do in the office. But then the next step that I'm going to take him through is a McKenzie press-up test. In order to do that, I'm going to have the patient go ahead and lay on his stomach here. There's a lot of different steps, and I'm just going to give you, a quick little overview. But really what we're looking to do is put them into extension. If you remember earlier in the video, we talked about extension being beneficial in the disc herniation. So I'll have the patient go ahead and just try and lift himself up, his chest off the table, as far as he can go to tolerance, and back down. He's going to keep those hips down. Go do a couple reps. We'll always do sets of 10. And if you're coming into the office with a disc herniation, you may find yourself doing, 50 to 60 different repetitions of these, because we want to see how your symptoms respond to it. Do the symptoms get better? If they were down in the leg, are they now higher up? Are they centralizing from down all the way into the spine? Those are positive changes that we're looking for. Sometimes we'll add some overpressure here, where I'm going to put a little support on the low back. Go ahead and lift up again, which is just going to be the next progression to this exercise. Based on how the patient responds to this exercise will really determine how we move forward. But this might be a take-home tool for the patient to use, because I like to call it like a first aid. It's something that if they have a flare-up while they're outside of the office, they can use this to help decrease their symptoms. It's really empowering to the patient to be able to have a tool that doesn't involve me in order to actually make their symptoms get better. So this is really, really valuable. And if you respond well to it when you have a disc herniation, we're gonna have a really good prognosis. And there are very few cases that respond well to McKenzie that are gonna need that further, referral to potentially an orthopedist or an MRI. So this is a really awesome tool. And if you come in with those types of symptoms that we talked about, we'll use it here in the office for sure. And then progress it with some more corrective exercises, some core stabilizing stuff. Okay, so one of the most important things that we're going to teach to any patient that comes in with back pain in general, but specifically disc herniations, is how to brace, how to use what we call intra-abdominal pressure to not only stabilize the spine, but also to help decompress the spine. So it's multifaceted in how it actually works for our patients, and it's a really important yet simple tool that we train. So in order to train this, what we talk about is breathing into our belly. So a lot of us tend to breathe with our chest. If you take a deep breath in, you might notice, yep, our chests rise, and you'll see this in a lot of our patients. It's not dysfunctional, but it's not ideal, and it doesn't accomplish what we're looking for. So we have our patient try and, put one hand on their chest, one hand on their belly, and I want to see this hand not move and this hand rise when they're breathing in. So Jesse's going to go ahead and try this for me, taking that deep breath in And you can see how it's expanding here. He's gonna do a few breaths like this, and I'm gonna talk about why does this work. Well, if you picture a beer can, right? If you have an open, empty beer can, you can stand on it, you can crush it. Well, if it's full, it's closed, and it's pressurized, like our belly here when we breathe into it with air, it's gonna be really strong and really stable. You could stand on it, it would hold your weight. So the same theory applies here. If we breathe in and we pressurize our abdomen, we have this cylinder right here that is going to support the spine. There's also the diaphragm on the top, the pelvic floor on the bottom, and if we fill that enough, you'll actually push against those tissues and you can create a decompressive force in the spine. And this can help take some of the pressure off of those discs and help relieve some of that tension and pain that you're getting going down the leg and whatnot. Once we've mastered this, we then progress it through all these core exercises. There's a ton of different ways that we can use it, but for the most basic patient, we're gonna have them push all the way out. They're gonna try and breathe with the pressure. So this is not hold your breath, this is keep pressure, but keep breathing. If you hear him, he's still breathing. Then you're gonna have them lift their legs up and try and hold that. This is a dead bug position that a lot of people are familiar with, but it's really important to see that the pressure is maintained. He's pulling his rib cage down, and then we wanna see that it's flat back against the table. I shouldn't be able to get my hands underneath, which is Jesse's doing a really good job. You can see he's already starting to shake. This is a great core stabilizing exercise, and it's not easy, but it's essential in the treatment of disc herniations. Okay, so you go ahead and put your legs down. The next thing I'm gonna have you do, go ahead and sit all the way up for me, right here. We're gonna talk about a nerve glide. What is a nerve glide? Well, a nerve is attached to both ends. It's in your spinal cord and it's at its final destination, whether it's a muscle in the toe or in the leg, whatever it can be. When you hold it at both ends, we wanna pull it back and forth to glide it through the tissue. Okay, how do you do that? Well, if we know what nerve is affected, let's pretend it's the sciatic nerve, which is a common one affected in these disc herniations. We can do what's called a nerve glide. So, remember I mentioned it's attached to the spine and it's attached to the leg. So that means both your head and your leg have to move at the same time. We call this the kicking your head off nerve glide because it kind of helps patients realize, okay, when my leg goes out, kick, toe all the way up, my head has to go back, kicking your head off. When the leg goes back down, the chin goes back down to the chest. So keep doing it for me, Jesse, and just picture we're moving that nerve up and we're sliding it back down. And what we're trying to do, this may irritate it at first, but what we're trying to do is if you picture that nerve gliding right along, say there's a muscle tissue right here that is kind of stuck on, or even that disc, when we get it, it can get adhered a little bit, right? We actually want it to move past it. So picture it being adhered. Every time you go, ow, 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 eventually it can break free and it can slide smoothly through those tissues. You'll find a moment of relief after sometimes it's 10, 20, 30, 40 reps, depending on how bad. It's super common to have to do multiple repetitions of this, but it's a really useful tool that patients will use when they're dealing with this type of condition. A couple keys to pay attention to. Go ahead and do it again for me. Going the wrong way. We're kicking our head off, remember, is end range. You want to go as far as you can in both directions if you can tolerate it, and then go back down again. End range is where the magic happens, where things, especially from extension to nerve glides, really make their biggest difference. So we want to try and push through that to the full range of motion. So now that we've talked about some of the different myths, the facts that are related to disc herniations and disc pain that's traveling down the leg, if you feel that you may have one of these issues, give us a call at 561-997-8898. Schedule a day of appointment. We'll get you in, we'll go through a full evaluation, and we'll provide some answers and some solutions to your injury that you're dealing with.